Your hands were made for greatness. Mighty hands for painting, paneling, and clicking the submit order button on HomeDepot.com to get that duvet. And these Egyptian cotton towels delivered right to your door. Do more with decor at the Home Depot. Save up to 30% on select bedding and bath. Now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Enter promo code BEDBATH15 at purchase for an extra 15% off. Visit HomeDepot.com for more information.
Welcome to Creating a Family, Talk About Infertility. Today we're going to be talking about the latest developments in the treatment of PCOS. I know that a lot of you are interested in that because we get a lot of questions about polycystic ovarian syndrome. So I know you're going to enjoy it. Here's a sample of what you're going to hear.
The important part of the name is it's a syndrome. So a syndrome, if you look up the definition of a syndrome on Google, it's a group of symptoms which consistently occur together or a condition characterized by a set of associated symptoms. What that means is it's not just one single body part that is involved or one single specific defect.
This show is brought to you by Creating a Family. We are the National Infertility Education and Support Nonprofit. I'm Dawn Davenport. I'm your host and the director, and you can find us and all of our resources online at creatingafamily.org. For women who have been undergoing infertility treatment and are still struggling to conceive, Ferring Pharmaceutical, which is one of the underwriters of our show, wants you to know about an app called Ferticom, the Ferticom app. It was designed specifically to help women address the many challenges and emotional life situations that arise when they're struggling to conceive. You can get more information about the app at ferticomapp.com. And let me spell that, ferticalmapp.com. Today we're going to be talking about the latest developments in the treatment of PCOS, polycystic ovary syndrome. We'll be talking with Dr. Alex Quaas. He is a reproductive endocrinologist with the Reproductive Partners Fertility Center in San Diego. He is both an MD and a PhD, and he serves on the board of directors of the Pacific Coast Reproductive Society and was the program chair for the 2017 annual meeting. He also serves on the board of Creating a Family. We are, of course, the National Infertility Education and Support Nonprofit, and he serves on the editorial boards of Fertility and Sterility and the Journal of Assisted Reproduction and Genetics. Welcome, Dr. Quaas, to Creating a Family. We are so happy to have you talk to us today about polycystic ovary syndrome. I know that's one of your special interests.
Yes, thank you for having me.
All right, well, to start, to not overstate the boring here, let's begin at the very beginning. And what is Well, first of all, I have a question. I see it written both ways. Is it polycystic ovary syndrome or polycystic ovarian syndrome, or am I getting a little too picky and to care one way or the other?
I would say you could use both terms, but in the literature, technically, most people use the term polycystic ovary syndrome. Like when you look at the literature. But I think it's perfectly fine to say polycystic ovarian syndrome as well.
Okay, perfect. Okay, it also goes by PCOS. A lot of people refer to it as that. So tell us what PCOS is and how it manifests in a woman.
Yeah, so basically, first of all, the important part of the name is it's a syndrome. So a syndrome, if you look up the definition of a syndrome on Google, it's a group of symptoms which consistently occur together or a condition characterized by a set of associated symptoms. What that means is it's not just one single body part that is involved or one single specific defect that causes one phenotype in one particular organ, but it's actually a set of symptoms and a set of, pathological manifestations that occur in multiple systems in the body. And so it's characterized by irregular menstrual periods, but also by androgenic symptoms. So basically by symptoms that are caused by increased levels of androgens in women. And it's also associated with other things, such as an increased risk of insulin resistance and diabetes. And from the irregular periods, also an increased risk of endometrial hyperplasia and cancer. So because it is a syndrome, it takes a lot more time to explain to patients what exactly the elements are that take part of it. But usually I start by saying that the agreed upon diagnostic criteria and the most accepted diagnostic criteria are called the Rotterdam criteria, are that a patient has to have 2 out of 3 features, including 2 out of 3 of the following: irregular periods / irregular ovulation, and then either clinical or biochemical signs of androgen excess, and a polycystic ovarian appearance of the ovaries on ultrasound. So 2 out of those 3, that gets you a diagnosis of PCOS.
And so when you're talking about excess androgen, is that the same thing as excess testosterone?
Well, testosterone is one of the androgens that we're talking about, but there are others. So it's a little bit like when you're talking about estrogens. Estradiol is one estrogen, but then there are others like estrone. And so androgens, include testosterone, but also other things like androstenedione. And so it's basically the set of male steroid hormones that are obviously present in males in much higher concentrations, and to a certain extent are also present in normal, quote-unquote, normal women, but at much lower levels. And so what I usually say is the levels of testosterone and other androgens in women with PCOS are basically higher than other women without PCOS, but lower than men.
And just run off some of the typical things that we associate with women who have higher levels of androgen. What are some of the things we would notice, or a woman might notice about her body?
Right. So the main things are hirsutism and acne. So hirsutism would be, that's the term for essentially excessive hair growth in areas of the body where it's not supposed to occur. So it can happen in the face, for example, on the upper lip or chin, but also in other areas such as the abdomen. And then acne would be, basically a tendency to have acne on the skin in multiple areas of the body.
Okay. How common is PCOS, and do you see a difference worldwide? Are there countries that have it more frequent than other countries? But first of all, let's talk about the U.S. and then we'll talk about worldwide.
So it is essentially in reproductive age women. It's thought to be the most common endocrine disorder. So the most common endocrine condition that occurs in women of reproductive age is PCOS. And then it's estimated that it's somewhere between 5 and 10% of all women have it. And it's also known, and we see that in clinical practice, that of the women who have infertility secondary to ovulatory problems, it is probably by far the most common cause.
Well, let me back up. You're not necessarily saying it's the most common cause for infertility. It sounds like what you're saying, it's the most common cause for women who are infertile because of ovulatory irregularities. Did I
Correct.
say that correctly? Okay, gotcha.
Correct.
Which is a large percentage of the women.
Exactly. So usually when a patient or a couple comes to see me, I usually say that the broad areas that we're going to investigate are male factor, anatomic factors in the female, ovarian reserve problems in the female, and ovulatory problems. So of those 4 that are all very common causes of infertility, ovulatory disorder, in the ovulatory disorders category, PCOS is probably the most common. And of course, it depends a little bit on the demographic of the population that you are seeing, because so PCOS is associated with obesity, and so in areas, and 80% of patients with PCOS are overweight. And also, and we'll maybe get to this later, if you have a propensity to develop PCOS, being overweight probably makes the phenotype more severe, so it makes it more marked. For example, the ovulatory dysfunction becomes more severe. And so in areas where obesity is more prevalent, there's probably also a higher prevalence of PCOS.
So when we were saying 5 to 10% of all women, that might be a U.S. statistic, but because we have a greater proportion, I'm not sure this is true anymore, we certainly have a greater percentage of our population that are obese than some other countries. Certainly not all, but does that mean that countries that have more obesity also have more PCOS?
That's probably correct to a certain extent, although the prevalence of PCOS is actually thought to be remarkably similar worldwide.
Okay, so it really is. Okay.
Yes, it's just that in areas where obesity is not as prevalent, we as practitioners probably end up seeing slightly higher numbers of so-called lean PCOS patients, so patients with a normal BMI who still have PCOS.
Mm-hmm. Yeah. Okay, is PCOS hereditary? I mean, if your mother had PCOS or your sister has it, are you more likely to have it?
Yes, there's definitely. I mean, the etiology is multifactorial, but there's definitely a genetic component. So if you have first-degree relatives, then there's probably a higher risk for yourself to get it. Also, it is closely associated, as I said earlier, with insulin resistance and diabetes. So in populations that have a higher rate of diabetes, and in patients who have a strong family history of diabetes, they probably also have a higher risk of having PCOS.
What about an ethnic or racial component? Do we see PCOS equal amongst different races, or do you see a distinction there as well?
Yeah, so there are, definitely higher rates of diabetes and PCOS in certain in certain ethnicities. For example, Southeast Asians.
They have a higher propensity towards diabetes and PCOS?
Correct.
Interesting. I would think African Americans might, simply because they do have I believe I'm right to say that African Americans have a higher percentage of diabetes, so than compared to other racial groups, at least in the U.S. So do you see a higher rate of PCOS in African American women?
I'm not really aware that that's the case. So African Americans certainly have a higher propensity to develop things like fibroids, leiomyomas, but I'm not aware of data to suggest that PCOS is more common in African Americans.
Okay, great. So now the $64 million question for most women and most medical practitioners. What causes PCOS? And I don't know if we don't know then specifically, then what are some of the theories?
Yeah, so it is complicated. It isn't 100% proven or demonstrated what causes it, and there is ongoing research on this topic. And of course, this is the part that's difficult to explain to patients, medical students, and residents, because it's not like, let's say in cystic fibrosis, we can say, okay, there's a defect in the, CFTR gene, and that is the etiology, and then you can essentially very clean and clear-cut say this is the cause. In PCOS, there are many theories and, very well documented theories, but there isn't one clear cause. I think it is generally accepted that it may start with increased androgen concentrations inside of the ovaries, so intra-ovarian androgen concentrations. And essentially, characteristics of the ovaries that even though the number of eggs inside of the ovaries and the number of follicles is very high, they basically just don't want to come out. So, I sometimes say to patients, so there are two types of problems with the ovary. There's one problem that your ovarian reserve is becoming less and less, so that's a problem with ovarian reserve. So, you're ovulating, but the number and the quality of the eggs is decreasing with time. That's usually not the problem with patients with PCOS, but because they have actually much higher number of follicles than other, women of their same age. But the problem is that the ovulation is not happening. And this probably starts through complicated mechanisms with intra-ovarian androgen concentrations. There is a two-cell theory, of how estrogen and androgens are made inside of the ovaries. So they're the so-called theca cells that produce androgens, and then those androgens go into the granulosa cells, and they're converted to estrogens. The theca cells are mainly stimulated by luteinizing hormone, or LH, and the granulosa cells mostly by FSH, or follicle stimulating hormone. And so in women with PCOS, the LH concentrations tend to be much higher, and so there's more androgen production inside of the ovaries. Now, this is not the whole story, because there's also an interplay between the metabolic system and the reproductive system of these patients. And so, as we said already, there's a higher risk of diabetes and insulin resistance. And this, the two systems basically interact and cause this inability to ovulate. And by the way, I need to say that not all women, or actually the majority of women with PCOS, do not necessarily not ovulate at all, but they may ovulate infrequently. So there's two terms for this. So anovulation means no ovulation at all. So, and that means usually no periods, or just breakthrough bleeding or breakthrough spotting. And then there's oligoovulation, which are women who have a prolonged follicular phase, so a longer time to the time of ovulation, but they still occasionally ovulate, let's say, for example, 3 times a year or 6 times a year instead of, let's say, 13 or 14 times a year.
So the cyst, I'm going to back up to something you said. One of the hallmarks of PCOS, under the Rotterdam criteria, one of the 3 things is the being able to visualize through some type of imaging that there are cysts on the ovaries, more than one, hence the polycyst, cystic. Those cysts are actually, this is the question, are those cysts actually egg follicle cysts, or are they a different type of cyst?
So that's a great question, and that's a question we get a lot from patients. So when I get that question, I usually back up a little bit, and I explain that basically a cyst is just any type of contained fluid-filled space inside of an organ. So you could have cysts of the liver, or cysts of the kidney, or cysts in the ovary. Now, a follicle, which is essentially a fluid-filled space inside of the ovary that harbors an egg, is a type of cyst. But usually, sometimes patients freak out a little bit when they're told about cysts, because, of course, there are other cysts that have higher implications, where maybe surgery has to be performed, or cysts where we don't know if they're benign and things like that. And so what I usually say is, a follicle is a type of cyst, just like a German Shepherd is a type of dog. But the other, it's basically one type of cyst, but it's a physiologic cyst.
Mm-hmm.
And
gotcha.
the follicles inside of the ovary, everybody has those, and every month an ovulatory woman will develop one dominant follicle that will become bigger, 2 centimeters, and technically that's a cyst. And then it goes away when it ovulates, it transforms into a corpus luteum, and then the whole cycle starts again, and the next month you'll have a different type of cyst that will be the dominant follicle of that month. So every month in ovulatory women in the normal menstrual cycle, there are many small follicles, which technically are cysts, that are usually a cohort of antral or early stage follicles that are getting ready to compete for who goes on to ovulate. Now, women with polycystic ovarian syndrome have lots and lots of those antral small follicles, and so technically they're cysts, and therefore the term polycystic.
Gotcha, but they're not necessarily. So they are. When you look at the ovary and you see the cyst on there, those all are follicles, egg follicles. However, they're not necessarily going to grow and develop the way that a normal follicle would. So they are they're cysts that are not going to result in an egg being released in a woman ovulating. Is that a correct summary? Okay,
that's correct.
Gotcha.
That's correct. And actually, while we have this topic, it's important to point out that there is an overlap between women who have the diagnosis of PCOS and, as part of that, have polycystic, quote-unquote, polycystic ovaries. There's an overlap between that population of women and basically just young, fertile women in their early 20s who, because they have a very, very good ovarian reserve, have a high follicle count. So when we talk about ovarian reserve, a lot of the listeners on the show and also some of the, practitioners and nurses have heard of the fact that we do an antral follicle count to determine the ovarian reserve. And these little antral follicles also produce a hormone called anti-Mullerian hormone, or AMH, which, because these follicles produce them, it's a marker of ovarian reserve. So essentially, a young 22-year-old woman might have a high antral follicle count and a high AMH because she's young and she's got a high ovarian reserve, and that population overlaps with women who have polycystic ovarian syndrome. And also, in some ways, quote-unquote, have too much of a good thing. They have a very high number of follicles and therefore a high AMH. And that actually brings me to another important point. The AMH level has actually recently been suggested as an additional potential diagnostic criteria for PCOS.
Oh, so there would be because going back to the Rotterdam criteria that you mentioned, a young 20-year-old who is at her peak of fertility might have a high AMH and if you looked at her ovaries through imaging, you might well see a larger number of follicles, but follicles that are developing. She wouldn't necessarily, however, have the other two symptoms.
Exactly.
So she would not be PCOS. She would just be young. So if a woman is,
exactly.
Well,
and actually,
go ahead. No, go ahead.
Yeah, and actually, this controversy or this part caused a fairly big debate in the community, OBGYN and REI community, because there were other diagnostic criteria that were used that were called the NIH criteria that did not exclude the ultrasound features, and people for years were arguing which ones were the better criteria to use, because let's say if you had a 24-year-old who for a different reason has irregular periods and then she has a high follicle count because she's young, then she would technically meet diagnostic criteria for PCOS. Now, that debate has been resolved because essentially most people now accept that the Rotterdam criteria are the accepted criteria that we should use, but also in the criteria it says that you have to rule out other causes of anovulation, such as, for example, thyroid disease or hyperprolactinemia before making the diagnosis.
So if a woman with PCOS is having more of her eggs come to, if not maturity, at least beginning the process, are women with PCOS more likely to enter menopause sooner or have a reduction of their total count, so primary ovarian insufficiency at a younger age, because they're running out, they're using up all their eggs, or do we have so many that it's simply not an issue?
It's more the latter. So, in fact, women with polycystic ovarian syndrome tend to have higher than average ovarian reserve, and therefore, if anything, their age at menopause might actually be higher than age-matched controls. So, essentially, the high number of follicles, the high AMH levels, they usually tend to actually more produce a phenomenon that even, let's say, in the late 30s or early 40s, we see women who used to have irregular periods and hirsutism and met criteria for polycystic ovarian syndrome, and the ovaries do not look like the ovaries of a 40-year-old, but essentially, quote-unquote, younger because the number of follicles is still higher than average. So, if anything, I would, I'm not aware of clear data to suggest this, but I would actually venture to guess that their age that they enter menopause might actually be higher than women without PCOS.
So, all of this talk about the women and having how many eggs they have leads us to the next question of how does PCOS impact fertility? That's
obviously the great question, and that's the core of what we do on a daily basis, because we see patients who have trouble getting pregnant, and typically the short answer is that because it prevents ovulation, there's no egg being released, and without an egg that's available to get fertilized, there also cannot be the subsequent steps of fertilization and then implantation and then embryo development. So, and fetal development and the development of a pregnancy. Now, I would like to just take a quick step back, because when I see a patient with polycystic ovarian syndrome, I try to emphasize that fertility is just one feature of it, and I usually try to cover other areas of the patient's life and health that PCOS can affect, and then essentially address the infertility, which is mostly secondary to the inability to ovulate. Okay, let me pause there and remind people that you are listening to Creating a Family. Today we are talking with Dr. Andrew Quaas about the latest developments in the treatment of PCOS, polycystic ovary syndrome. Hey, if you're listening to this show, do us a favor. Please go over to iTunes and write a quick review, or just give us a star rating. Look, we'd be happy with either. We really do appreciate them. We read every single one, and the ones that particularly touch us, we send around to all the people on staff and to our board members and say, hey, this is what we're doing. And so it means a lot to us, and we really, really would appreciate that you, if you would pop over there and do it. Super easy. Just go to iTunes, type in Creating a Family, and you can rate us right there.
Let me remind everybody that this show is brought to you by the support of agencies and clinics who believe in our mission of providing unbiased education and support to the patient community. One such partner is Reproductive Medicine Associates of New York. They are one of the largest fertility practices in the state and one of the largest in the country. By combining the latest innovations in the reproductive sciences with compassionate and customized treatment plans, RMA of New York is able to provide the best possible care. All right, so we're talking about the latest developments in PCOS, and we're talking about the various treatment options. And you mentioned before, going back a little bit, you said that one of the things to realize about women with PCOS is it's not that many of them simply never ovulate, it's that they ovulate less frequently. So I'm wondering if from the standpoint of a woman who is struggling to get pregnant, is PCOS more of something that would make her subfertile rather than infertile, whereas if she kept trying, she stood just on her own without treatment, would she stand a chance, because if she happens to have intercourse during a time, the 3 times a year that she is ovulating, she would get pregnant?
That's exactly right. So it depends on the severity of PCOS because, often in young women, let's say in their early 20s, it might be enough to ovulate 3 times a year if they have regular intercourse, because the fecundity per ovulation is relatively high, and so they may still conceive without any additional assistance. But before, obviously, making that, conclusion, maybe it's worthwhile to assess that and to maybe follow a patient over a period of time to see if ovulation does occur at all or if it doesn't occur, and essentially work on that. The other thing to note is that women can influence the frequency of ovulation by lifestyle modification. So, for example, if a woman has PCOS and her BMI is 40, if she makes lifestyle changes such as regular exercise and a healthy diet, then it is possible, it's not guaranteed, I tell my patients it's not guaranteed, but it is possible or even likely that her periods may become more regular as these lifestyle changes are implemented and the patient loses weight.
Does she still technically have PCOS, but she's just reducing the symptoms? And another way of saying that would be increasing the number of times that she might ovulate, thus increasing the number of times that she has a chance of getting pregnant.
Well, as I said at the very beginning, polycystic ovarian syndrome or ovary syndrome is a syndrome, and so what people have to keep in mind is that there's a spectrum of severity of the phenotype, and I would say it is one of the most commonly misdiagnosed conditions in our field because it's not black and white, but more like shades of gray. So we, technically all we can do is apply the Rotterdam criteria and say whether at this moment in time a patient meets the diagnostic criteria for PCOS. But it may be that in 5 years' time, when the patient is 5 years older and let's say maybe it's because of lifestyle changes 40 pounds less heavy, it could be that the diagnostic criteria are no longer met.
Gotcha. And going back to another, women who are young, one of the reasons that diagnosing even younger women with PCOS, there's a host of reasons. One, it affects other parts of the body, and it is good for women to know about these so that they can be proactive with their health. But another reason, it seems to me, would be that if you know that you have PCOS, your chances of getting pregnant are going to be greater when you're younger because at your most fertile. Because as you age, even women with PCOS, I would assume would have the natural reduction of fertility. So if a woman is diagnosed earlier, she might make different choices as to when she builds her family. Would you agree with any of all that I just said?
Yes. I mean, I think that it's important to be aware of the diagnosis. The sooner it's possible to make that diagnosis, the better, because mainly because of all the other health features, but also then women can plan their fertility plans and essentially ensure that they can build a family the way that they wish to. The other features that I talked about earlier that I usually address with every patient that has polycystic ovarian syndrome or where I suspect it are the fact that general health is maybe the most central priority for us as physicians, because women with polycystic ovarian syndrome have a higher risk of developing metabolic syndrome, a higher risk of developing diabetes. And so it's very important to address these things, especially in overweight women, at the first visit. Women might come to us with other concerns, for example, the cosmetic issues like the hirsutism and the acne. But it's our job to point out these other health features and these other risks that may happen over the next few years, such as metabolic syndrome, cardiac disease, diabetes, and we always screen for these things. So we do diabetes screening, we check a lipid panel to look at these things. And so it's important to look at these features because in addition to conceiving and getting pregnant, other things that I point out to patients is you also want to have a healthy pregnancy and then be there for your child, hopefully, as it grows up by reducing your risk of diabetes, reducing your risk of cardiac disease, and living a healthy and long life. And so at the time of diagnosis of PCOS, in addition to addressing the fertility, it's also, I think, our duty to set the stage for a healthy, long life with minimization of other health risks.
And you had mentioned at the beginning that women with PCOS have a higher risk for a certain type of cancer. Can you tell us a little more about that?
Yes. So in the normal menstrual cycle, let's say 28-day cycle, the follicular phase, so the phase from the day one of the cycle, which is the first day of bleeding, until the day of ovulation is the follicular phase, and that's the phase where a follicle out of the group of antral follicles, out of the group of the small follicles that we've talked about, selects itself out and then goes on to ovulate. And then actually at the site of the ovulated follicle, there is something developing called a corpus luteum, and that corpus luteum produces progesterone, which essentially prepares the lining of the uterus or the endometrium for implantation. Now, in women, so sometimes I used to tell medical students that estrogen and progesterone are like a bit like the yin and yang of the female menstrual cycle and of the sort of endocrinology of the ovary. Now, in women with PCOS, essentially that follicular phase where you get that buildup of the endometrium under the influence of estrogen from the follicles, that phase essentially goes on and on and on without ovulation because of the diagnosis of PCOS. So then there's never that counterbalance of progesterone that happens, the progesterone that comes from the corpus luteum, the corpus luteum will only be there if ovulation has occurred. So that protective effect of the endometrium or on the endometrium of progesterone is essentially absent if somebody doesn't ovulate. And so in women with severe PCOS with complete anovulation, the estrogen is essentially unopposed. And unopposed estrogen is a risk factor for endometrial hyperplasia, which is thickening of the lining of the uterus, which eventually, if untreated, can lead to endometrial cancer.
Okay, so that is a, and how would a woman who has PCOS, who after hearing this are being told by her nurse that she might be at, or doctor, that she might be at increased risk for endometrial cancer, what type of a pap smear is not normally done for? Is that what type of testing should she be concerned about or asking for, knowing that she might be at an increased risk?
So pap smears we usually do to look at the cells of the cervix. To look at the endometrium, we actually have to do an endometrial biopsy. So we essentially put a little, pipelle, which is a little straw, into the uterus and then get some tissue from the lining of the uterus. Now this test, which is not the most comfortable test, it's a little bit crampy, is only necessary if we really suspect, based on the history, that there is a, let's say, reasonable risk that hyperplasia or endometrial cancer might be present. And basically, I would say ask your OBGYN or your fertility physician whether this is necessary based on the length of time that the periods have been either irregular or absent. And that depends on other factors such as comorbidities, BMI, and also, the age of the patient, because let's say if somebody hasn't had a period for 3 months, for example, that's not a long enough time usually to develop this hyperplasia or, God forbid, cancer. So typically, it can actually be prevented relatively easily by administering progestin, the progesterone. So progesterone is the natural hormone. Progestin is a synthetic version of progesterone. So if you give a patient cyclic progestins, then that essentially takes away the risk of hyperplasia and cancer. And so basically, if somebody ovulates normally, then they don't have that risk. Or if they're on the pill, which contains estrogen and a progestin, then that risk is lower. And also, if through the fertility treatment ovulation is induced successfully, that will also help protect the endometrium.
Yeah. Okay. Because you're then having progesterone to counteract to oppose the estrogen.
Exactly.
Gotcha. A question that we often get and ask in different ways is about the role of weight in PCOS, and it's kind of the chicken versus the egg thing. Is the weight the cause of PCOS or the symptom of PCOS?
It's not the cause. So not every overweight woman will have PCOS, and in fact, some overweight or even obese women will have very regular periods and no hirsutism. But it's certainly an exacerbating factor, and for complicated and multifactorial reasons, obesity and being overweight is more common in women with PCOS. So it's not the root cause, but it is a exacerbating factor that essentially can be removed by lifestyle changes.
And it seems like many women with PCOS report that they simply have a harder time losing weight. They're eating similar to other people. They're exercising similar, and yet for them, it is simply harder to lose weight and conversely easier to gain weight. Is there medical evidence of that? Or because I think sometimes women think, I'm just not trying, or maybe it's not the women themselves, it's others in their lives who think, you're just not trying hard enough. Is it harder for women with PCOS to lose weight and conversely easier for them to gain weight?
I think losing weight is hard for probably anyone who is overweight or obese, and it's obviously it's a public health problem, in many countries, but especially the United States, that is difficult to treat. And women, most women obviously would love to lose the weight if it was easy, but I think it's very difficult for everyone who struggles with that. I would say that anecdotally, in patients with PCOS, it appears to be particularly hard to lose weight. I'm not sure that there's medical evidence that demonstrates that it is, that physiologically it's harder. But I think that the hormonal situation and the metabolic situation certainly don't make it easy. But I still encourage patients to try, and I typically, recommend a combination of dietary changes, but also exercise. So some patients haven't necessarily tried, let's say, for example, even simple interventions like going for a walk for half an hour after dinner and things like that. But I also usually talk about the role of different food components, for example, refined sugars. So some, women are not aware, just how much sugar, for example, there is in soda and other foods. And so I usually try, I'm not a nutritionist, obviously, but I usually try to ask, how much soda do you drink? Is it full sugar soda? What type of, foods do you typically eat? Tell me about a usual day. And then typically I recommend, increasing the amount of protein and reducing the amount of carbs that people eat. And very important, meal tracking. So I think like in our population, only a minority of people are actually able to remember at the end of a long day all the things that they ate and drank that day. So meal tracking, in my opinion, is the beginning of it all. So to answer your question, I do think it's hard for anybody, but it does appear, at least anecdotally, to be particularly hard for patients with PCOS.
And is there a treatment? Well, you've talked about lifestyle changes and including losing weight. But is there a medical treatment, which I realize changing lifestyles and recommending that is a medical treatment. But is there a treatment for this disease in general? Now, I'm going to circle back in a minute, and we're going to talk about fertility treatment for women with PCOS. But in general, for even women who are not wanting to get pregnant, is there any type of treatment that would help offset what's fundamentally going on in their body, which is causing these symptoms and this increased androgens?
Yeah, so that's been the sort of ongoing research topic in the field of PCOS. Like, how are there things that we can do to maybe help with the weight loss, but at the same time also help with the other features of PCOS? And so the big medication in this context that has been researched over the years, obviously amongst others, but this is the one that's most discussed, is metformin, which is essentially a diabetes medication that can essentially help with the treatment of insulin resistance. Metformin is something that, when I said earlier that polycystic ovarian syndrome is one of the most commonly misdiagnosed conditions, both in the positive and in the negative way. So patients with PCOS are not appropriately diagnosed, and then women who don't have it are labeled PCOS by their doctors. So, when I said that it's the most commonly misdiagnosed condition, I would say, in my experience, metformin is probably the most misprescribed medication, especially in women who are suspected to have PCOS. And so how did this come about? So essentially, in the early 2000s, it was found that this medication metformin, which is a diabetes medication that can help lower sugar levels in diabetics. It's an oral medication. It was discovered that this medication, in addition to maybe helping women who are insulin resistant or even diabetic, that it could also help women ovulate more regularly if they had PCOS because of this previously described overlap between the reproductive system and the metabolic system in PCOS. There was a lot of excitement and enthusiasm, and I remember that because it's sort of around the time of my residency. But then later, many studies were done, and actually they found that metformin, while it's probably superior to doing nothing in terms of inducing periods, regulating them, it was actually second best for most indications that are related to PCOS. So the weight gain, for example, it's been shown that diet and exercise, even though it's hard, are better if they're done properly than using metformin. With respect to ovulation induction, which is essentially the fertility part of PCOS, it's also been found that metformin is second best. So essentially, metformin was the medication that people got most excited about, but that enthusiasm for most people who follow the literature has decreased over the years.
Interesting. And there was some new research that came out, I read about it this year. I'm not sure when it was actually, the research was actually done, pointing to a cause, a potential cause, a theory of a cause for PCOS as a hormonal imbalance, inter-utero hormonal imbalance, where the fetus was exposed to higher levels of AMH, anti-Mullerian hormone, during pregnancy. And then and I think the hope was that if the research pans out to show that might be true, it might lead to other forms of treatment. Have you, I'm not trying to put you under the spot, but have you read anything about that research, and is it panning out? It's in its earlier stages, I believe.
Yes, I would say that's in the earlier stages. So definitely, I've also come across this study that was published last year in Nature Medicine, and so it essentially shows the or investigates the role of AMH, which we've talked about, anti-Mullerian hormone, in the pathogenesis of PCOS. And so that study looked at whether maybe, anti-Mullerian hormone levels, which are elevated in patients with PCOS, whether high levels of this may actually in utero reprogram the fetus and then induce polycystic ovarian syndrome in the adult after it did that. And actually the authors of that study presented some animal data where they had mice where they exposed them to AMH and they developed the PCOS phenotype. And then when they actually used GnRH antagonist treatment, then they were able to, which essentially is a medication to block the reproductive axis, which was thought to be hyper activated, then they could restore a normal phenotype in these mice. Now, I feel like often in PCOS, what we battle with or what we struggle with is to decide what is chicken and what is egg. So what is the root cause? And essentially we know for sure that AMH levels from recent research that AMH levels are elevated in women with PCOS, but how it factors into the pathogenesis of the syndrome and how it could be used therapeutically, I think remains to be seen.
Yeah, it does seem like with PCOS there are a lot of, as you say, chicken and egg scenarios, and I think it's because there's still so much we don't know about the disease, and because it's a syndrome, and so it's a compilation of different things.
Yeah, and that makes and that makes the research harder because, especially when people didn't necessarily accept the Rotterdam criteria as the university accepted criteria. That you could read 5 different papers, and all of them used maybe slightly different inclusion criteria for their patient population, and so that tends to complicate research.
Yeah, absolutely. And so it's also hard to control to set up your controls.
Exactly.
What about now for as a reproductive endocrinologist? The endocrinologist part of what you do, regardless of whether somebody is trying to get pregnant. But I suspect that you see a lot of patients who are coming to you because they want to get pregnant. So what is the standard treatment for a woman who has PCOS, and by the time she's coming to you, she clearly has not gotten pregnant on her own? One would assume that if she could get pregnant on her own, she would have. So she's not ovulating frequently enough or able to time her intercourse to coincide with her irregular ovulation. So what's the standard protocol for treatment for women with PCOS?
Yeah, so that's a very important question, and obviously maybe the question that listeners might be most interested in. So I just want to take one little step back, and so what we haven't mentioned is the syndrome PCOS used to be called Stein-Leventhal syndrome because in the 20th century, some physicians called Stein and Leventhal described this case series of patients who essentially had features of hirsutism, irregular periods, and enlarged ovaries, and they incidentally found that if you actually do a wedge resection of the ovaries, so if you take away a chunk of the ovary, that these patients started to ovulate again. It was a small case series, but that has been later reproduced, and so it was thought that the androgen burden of the ovary is decreased if you just physically take away a portion of the ovary. So that is one treatment approach, but that's not used commonly. Typically, because there's a treatment called ovarian drilling or ovarian diathermy that can be done, that would be a surgical approach. But most of the approaches to induce ovulation are medical. And so the medical approaches to inducing ovulation. So I've talked about metformin earlier, and people were very excited about that and maybe thought that every patient with PCOS should be on metformin and that might just make them all ovulate again. It's actually been found, so there were several landmark studies in this area, often done by the Reproductive Medicine Network, basically multi-center study. And one of the ones asked the question, is metformin better, which acts more on the metabolic component, and then through the interplay between the metabolic component and the reproductive component can also restore periods, or Clomid, which Clomid is, a very frequently used medication in our field for two things: to induce ovulation in women who are not ovulating, but also to make women ovulate more follicles in those who are already ovulatory. Now, in the study that was done basically in the early 2000s and published in 2004, I believe, the results of the study suggested that Clomid is actually better than metformin at inducing ovulation. So that led to us using clomiphene as the first-line treatment, and that's oral ovulation induction. Now, alongside, there's another medication called letrozole or Femara, is the brand name, that was actually, that's an aromatase inhibitor, so it inhibits the conversion of androgens to estrogen and thereby lowers estrogen levels. That was mostly used in the field of cancer and women with breast cancer to lower their estrogen levels to prevent a recurrence of breast cancer in the future. Now, it's been found that that was effective too, but the question over the years was, is it better, worse, or the same than Clomid? And so a couple of years ago in 2014, another multi-center study from the Reproductive Medicine Network came out, and actually it showed that the letrozole or Femara was better than the Clomid. And so, to cut a long story short, I personally use letrozole or Femara as the first-line oral agent to induce ovulation in patients with polycystic ovarian syndrome. Now, quickly, if that doesn't work, the other options are injectable medications to induce ovulation, and then last resort, IVF.
Okay, so the first one would be letrozole, which brand name is Femara. And then when you mentioned injectables, that is we think of those as the gonadotropins, and they are their role is to stimulate the ovaries. And so how effective are gonadotropins for women with PCOS? And then does it have the effect of significantly increasing their risk of producing too many? Since we've already talked about that, too many eggs, because we've already talked about the fact that they often have a good egg reserve. So is that the risk of how effective is it, and what's the risk of using it with women with PCOS?
Absolutely. So they are very effective. So as I said, typically we start with oral agents because they're easier to take, they're cheaper, it's more patient-friendly. And by the way, one more word about the letrozole. There was a controversy about birth defects with letrozole and Clomid, and for a while there was a black box warning from the manufacturer that told us not to use letrozole, which sort of hampered the development or inhibited us using it more commonly. And so for a while, Clomid was the tried and tested medications, and we didn't want to use letrozole because of these concerns. I think most people agree that these concerns have completely been, shown as unwarranted. And so I think we all feel like letrozole is safe to use. But anyway, so after letrozole and or Clomid have failed to induce ovulation using an oral medication, then we use the injectables, the gonadotropins, which you're absolutely correct. They're usually FSH with maybe an LH component, but women with PCOS have very high LH levels, as we mentioned earlier, so usually they just need FSH, so follicle-stimulating hormone. They're very effective, but you're absolutely right. Because of the high number of follicles, there is a high risk that if we induce ovulation and then the patient does timed intercourse or intrauterine insemination, there's a high risk of multiple pregnancies. So these cycles need to be very closely monitored, and they're often very challenging for us because there's a narrow therapeutic window where the FSH actually works, because what happens sometimes is we essentially use very, very low doses of FSH because we want to be cautious because of this multifollicular development. And then typically nothing happens. We do multiple ultrasounds, and then suddenly when we cross a certain threshold of FSH, then suddenly the patient might develop 4, 5, 6 follicles, and we have to cancel the cycle. So these are sometimes very tedious cycles. They're effective but tedious, and so sometimes we end up converting them to IVF, and sometimes we have to cancel the cycle and then maybe talk to the patient about whether IVF might be a better option, because with IVF, essentially, you can take all these eggs out, make the embryos, as we usually do in the laboratories, and then transfer one embryo at a time with the goal of producing a singleton live birth.
Yeah, exactly, and it's a hard thing. It's a hard sell sometimes for patients because of the cost of IVF, but ultimately, so much of the cost is in the medications anyway, which if you have already moved up to the injectable gonadotropins, you're already incurring that cost. So in some ways, you could argue that IVF might well be the less expensive because there's less risk of having to either cancel the cycle or try to convert it, and it's less effective to convert at that point. So
That's true. Although that is very true. Although in patients with PCOS, the actual effective doses of gonadotropins that we need are much lower than let's say in a patient with reduced ovary. So sometimes we use just let's say 50 units of FSH, and so use that for 10 days or so, and so it ends up being much lower total units. But it's true, these medications are in fact expensive, and when you look at the cost effectiveness of all that and the length of time until pregnancy, it's a close call because the success rate of IVF in young women with PCOS is extremely high, and it's very safe because we can do single embryo transfer and produce one pregnancy at a time, singleton pregnancy at a time, and freeze embryos for the future, so we don't need to do it over and over again. Whereas with the FSH plus IUI or timed intercourse, we might need multiple cycles.
Yeah, and the bottom line is that this is why you're going to a reproductive endocrinologist, is for them to tell you and to help assess the best way for you to get pregnant and to have your family. Well, thank you so much, Dr. Alex Quaas, for being with us today. This has been fascinating, and I really appreciate your time. So thank you.
Well, thank you so much for having me, and I really appreciated the opportunity and enjoyed it.
Thanks. Let me remind everyone that this show is brought to you with the support of our partners, and one such partner is Fairfax Cryobank. They are dedicated to providing donor recipients and their children the information they want and need. Fairfax contacts their donors every year to get current medical and personal information to provide to recipient families long after the conception. When the donors respond, the information is posted on the donor page, and the recipient families can go there and get it. This is a reminder that the information presented today is meant to be in general in its nature. It is not meant to diagnose or to treat you. You need to check with your infertility professionals to get direct advice there as well. And also, please note that the information is the opinion of the guest and not necessarily the opinion of the underwriters or partners or creating a family. Thank you so much for listening to us today, and we will see you next week.
Napa Know-How. It's Love Your Car Month at Napa. And to show your car the love, get a Napa bucket for $2.99 and save 20% on almost everything you can fit inside, like car wash, car wax, and tire shine. So save some cash and look good doing it by getting 20% off with the Napa bucket. Quality parts, helpful people. That's Napa Know-How. Napa Know-How. At participating Napa Auto Parts stores. Exclusions apply. Minimum 3 items. May not be combined with other offers. Offer ends 4/30/19.
Everything you're hearing is from the Home Depot. From the baseboards and nails to these throw pillows, even those super soft sheets. Because now at the Home Depot, you can get everything for your bedroom, from wooden nightstands to modern benches. Save up to 25% on select bedroom furniture, plus free and flexible delivery and easy in-store returns. Shop decor now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Visit HomeDepot.com for more information.